So may I invite Dr. Raghav? He's a cataract refractive surgeon in Center for Sight.
Thank you, Dr. Tulika, for this wonderful opportunity. So today I'll be speaking about red flags in a pre-laser vision correction procedure. So our job basically is to reject and find the right candidate for the procedures. So the purpose of my talk will be to find the right candidate and, more importantly, to reject the right candidate. So rejecting is more important than finding the right one. So of course, what cornea are predisposed to a LASIK ectasia? It could be a cornea that is already destined to manifest ectasia later on. Corneas which do not have any apparent changes in the cornea preoperatively, but might out in the future. So such a patient, if we operate and then the patient tends to go towards ectasia, will have an ectasia. A preoperatively weak, that is a baseline, or I would say a borderline topography that undergoes surgery, and a relatively normal cornea which is weakened beyond its safety margins. That is, if we go beyond 40% of percentage tissue altered, that could undergo an ectasia. So we have to evaluate our patients very well. Most and foremost important is, of course, the history. Whether the patient has any particular if the patient is on any particular medication, any family history of ectasia, any family history of corneal procedures, any family history of any corneal diseases, we should know very well. The age of the patient is very important, yes, because age is a very important and natural cross-linker. So a young patient undergoing refractive surgery is predisposed to ectasia much more than an elder patient. So if our patients are less than 25, we should always be careful. This is, of course, given very well by Dr. Randleman in his score. Thirdly, sex of the patient. Many I would say many papers say that yes, males are a bit more predisposed, but yes, females should also be warned that after pregnancy they can have a chance of increase in ectasia. So patients should be warned about that. Occupation of the patient. There are certain patients who are working in dusty environments, so they will tend to have more allergic reaction, and then they tend to rub their eyes more often. Stability of refraction is very important. We want to wait for at least 6 months prior to our surgeries. Expectation, setting the right expectations is very important. The patient and the doctor should be on the same page vis-a-vis the expectation that the patient has, whether and what timeline we are looking at for visual recovery. And lastly, and not least important, that is general and the ocular health. General health, if the patient is on any systemic medication which can ultimately change our refraction and also change our biomechanics. There are some absolute general health contraindications, that is an autoimmune disease like arthritis or an SLE or a thyroid disease, for which the patient might be on treatment, which can affect our ocular surface also. Immune suppression, HIV or any immune suppression drugs, we should also know about that, and they are absolute contraindications. Pregnancy, yes, pregnancy and lactation, we want to wait at least 6 months after lactation has stopped. And if the patient is on systemic steroids, then we know that yes, the healing can be altered. Some relative general health contraindications could be tricyclics or lithium-based medications. If patient is on such a medication, yes, the patient could have borderline personality issues. Then yes, there could be a mismatch between the patient and the surgeon's expectations for results. Diabetes, though diabetics are also cross-linked, but yes, they can have more changes on the epithelium, so we can have ocular surface disorders, and the patient's refraction might be varying, and the patient can also have an early cataract. So these things must be considered. Active atopy, any patient who has an active atopy would most probably be on systemic or topical steroids, so that is something very important. Epilepsy, if the patient is on epilepsy medication. History of frequent falling, and hepatitis B and C, which could be a potential risk to the surgical staff. Absolute ocular health contraindications could be diabetic retinopathy, glaucoma, corneal dystrophies like keratoconus. Of course, we search for keratoconus prior to our refractive surgeries. History of any ocular inflammatory disorders, hepatic ocular disease which might reactivate after our surgery. Sjogren syndrome can get accentuated. Fuchs endothelial dystrophy, some studies say that yes, because of the endothelial irregularities, we can have flap instability and the flap might not stick very well. Unstable refractive errors and clinically significant cataracts. Some relative ocular health indications, contraindications like a dry eye, blepharitis, nystagmus, and squint. The ophthalmic examination should include all these, but is not exhaustive list. But yes, we should have the UCVA and BCVA measured. The refraction should be done, manifest and cycloplegic. For symmetry for spectacles to see the stability of the power. Ocular dominance should be tested for, especially in the pre-presbyopic age groups, because we do require to see which eye is dominant so that we can plan. Tonometry, yes, to see the pressures. Tear film assessment, anterior eye examinations, dilated fundoscopy to rule out any problems in the retina. Pachymetry, yes, part of our clinical workup. Specular microscopy and orbit configuration, because orbit configuration is very important, because we can have problems in docking the patient. So now coming on to the topography and tomography. So this is of course a pentacam. On the top left we can see that these are the patient identifying features. Yeah. The patient identifying features are on the top left. Then we have the corneal front and the back of the corneal measurements. That is, we have the keratometry in terms of diopters as well as millimeters, and also on the back. And very important is the astigmatism, which we should confirm with our spectacle power that the astigmatism is matching. If there is a mismatch, we can be looking at a lenticular or a total eye astigmatism. And also we're looking at the pachymetry, which we'll come to later on. And the front map, you can see this is the actual curvature. Very important. We will look at the type of curvature, whether it is a skewed axis, whether it's a symmetric or an asymmetric bow tie. Then coming on to the pachymetry map, this should be, yes, we know our cornea is thinner in the center and thicker in the periphery. If there is any ectasia, yes, we will see a thinning in that particular part of the cornea. Then elevation maps, which is very, very important. Now that we are looking at tomography, we are also looking at the posterior elevation of the cornea. And since we have started looking at the posterior cornea, the incidence of ectasia has further decreased. Why? Because our ectasia start in the posterior float first and then come on to the anterior. And on the right, you can see this is the Bellin-Ambrosi enhanced ectasia map. You can see that this is the first 4 maps, 1, 2, 3, 4. These maps are the front and the back with the best fit sphere. So if you compare our cornea with the best fit sphere, if our cornea is raising at portions above the best fit spheres, we will have some elevation points. And if this manifests into the difference map, yes, the chances of ectasia are higher. So like I said, this is the quality specification, whether the quality of the pentacam is fine or not. Then coming on to the center of the pupil, this is the pachymetry map. We have to see in a perfectly spherical, I would say, not a spherical, but yes, if we have a perfect cornea, all the points should be coinciding, but they are not. So in case you have this is the pachymetry at the center of the pupil and the pachymetry at the apex and the thinnest point. So if we do have a mismatch between the apex of the pachymetry and the thinnest location, that means that we are looking at a displaced thinnest point of the cornea, which could be an early sign of ectasia. Then also we have the we show the different ICs showing the corneal volume, the anterior chamber volume, and the AC depth, which can give us a very good indicator whether the patient is fit for an phakic IOL or not. So a Kmax less than 48 is very important. If you're looking at readings above 48, we are looking at red flags. Then also difference between the Kmax and K2 of more than 1 diopter is a red flag again. So this is the sagittal map. We can see this is a symmetric bow tie giving us the steep axis and the flat axis, and the 2 opposing points on the 5 millimeter circle. We can see this is the OD, the right eye, and the temporal and the nasal part of the cornea. Information we can have on the curvature map: the flat K, the steep K, the mean K, and the Kmax. Also the corneal apex and the pupillary center. And the pattern we have to recognize whether if there is an inferior superior asymmetry or a superior inferior asymmetry. So this is a perfectly symmetric bow tie showing a with the rule astigmatism, and this is the steep axis. Similarly, you can see this is an I would say a symmetric bow tie with against the rule astigmatism, and this is an oblique astigmatism showing the steep axis. Skewing of more than 30 degrees is described as a significant abnormality, and should be a red flag for a pre-LVC workup. There are some abnormal maps on the curvature which we have to look out for. This is a symmetric bow tie but with a skew of more than 22 degrees, which is significant. And also this is a asymmetric bow tie. This is also an asymmetric bow tie. So this is a skewing of the axis more than 22 degrees. This is superior to inferior asymmetry of more than 2.5 diopters, and this is inferior to superior asymmetry of more than 1.5 diopters. All of these are, of course, since we have an inferior steepening, that is the threshold for us to expect an ectasia is much lower. These are some abnormal patterns. This is a junction or a vertical D, or a smiling face ectasia, a vortex, or a crab claw showing a PMCD. So the elevation and the elevation subtraction maps, like I told you, if we are comparing the corneal surface with the best fit sphere, if our corneal surface is jutting out of that best fit sphere, we will have an elevation or a plus point, and if it is below that reference sphere, we will have a negative point. So all the hotter colors are showing an ectasia, red colors, and all the cooler colors are showing points which are below the reference line. So the elevation map with the best fit, like I described, this is the symmetric bow tie. So there are certain points which we have to consider for the anterior and the posterior elevation. In the anterior elevation, the cutoffs for a refractive, for a myopic, is about 8 diopters, and in posterior it is 18. So it is 8 and 18 for myopic, and 7 and 28 for hyperopic. Pachymetric landmarks, corneal apex, the thinnest location, 2 opposing points. So we have to look at the, like I said, in a perfect cornea, all these points will be coinciding, but of course, not all corneas are perfect, but we have to look at the pathological corneas where we will have more difference between those points. So this is the difference between on the 5 millimeter circle between the inferior and superior, and the thinnest location and the center of the cornea. So very important points: difference between the pachymetry of the thinnest location and corneal apex should be less than 10 microns. More than 10 could be a red flag. Abnormal thinnest point of more than 470 in normal topography, or less than 500 in abnormal. And difference in the inter-eye thickness of less than 30 microns should be there. So inferior displacement of y coordinate is very sensitive. If we have inferior displacement of the y coordinate showing that the ectasia or the thinnest point is far away from the center of the thinnest center of the apex of the cornea, that shows a displacement and is a red flag. So this shows this is the center and this is the displacement. Okay. So enhanced ectasia skinning includes a Berin-Ambrosio map, which we have discussed, a corneal thickness spatial profile, and a percentage thickness increase. This shows that yes, there is a corneal thickness spatial profile and the percentage thickness increase. How the percentage or how the cornea is increasing in thickness from the center to the periphery. If this is outside the 2 standard deviation points, the chance of ectasia are higher. Early detection of subtle changes could be corneal biomechanics, epithelial thickness spatial profile, and Bowman's membrane thickness. So yes, corneal biomechanics has come into the picture recently, but it is very important. If we do if we look at the corvus, we do have a bad D from the pentacam, and we have the TBI, that is the CBI, that is the corneal biomechanical index. But when we fuse together, we have the TBI showing the biomechanical strength of the cornea. This is the epithelial mapping showing us any irregularities. So we should have a percentage thickness alteration ablation less than 40%. More than that could be a chance of ectasia. And of course, now we have on the horizon artificial intelligence. So that could give us a lot of information and tell us much beforehand if there's a chance of ectasia. Thank you. I'm sorry, I can't take questions.
Thank you.